In the last video, we looked at the signs and symptoms of delirium. We considered some of the risk factors for delirium, and we saw firsthand the impact delirium has on family. We also explored the differences between those 3 Ds, depression, dementia, and delirium. So in this video, we're going to look at the team approach we take here at Southern, and you're going to learn about the Confusion Assessment Method tools, known as CAM tools, that we use as part of the delirium pathway. You'll get to understand the 4 features we use for CAM assessment and what needs to be present on the CAM tool. And you'll see a little bit about how the CAM looks in practice, and we'll share some examples, tools and tips for improving patient outcomes. So let's just remind ourselves of the delirium definition. Remember, delirium is a syndrome characterized by the rapid onset and fluctuation of altered mental status. It affects attention and cognition. It is a medical emergency, and it's subtly distinct from dementia and depression. It can affect anyone at any time. The CAM tool, short for Confusion Assessment Method, is a well-validated method with a sensitivity of around 81 to 90% when used correctly, which is what you will be able to do by the end of this training. This tool is great for helping you to differentiate between delirium and dementia, 2 of those 3 Ds, and it can even help detect the onset of delirium during admission. One of the great things about the CAM tool is that it's really simple to administer, and yet it makes a very real difference to outcomes. It's very much a team approach. So let's have a look at the CAM tool in more detail. And in the method, the patient is asked a series of questions and given a score based on their responses. Once you've tallied up the score, you get a clear indication whether delirium is present or potentially developing. It's completed on admission and on every shift for 5 days for all patients over 65. It consists of 4 features and the patient is scored. Their score indicates if delirium is present or developing. So let's explore those features before we look at the CAM tool in more detail. The first feature is acute onset and fluctuating course. And the questions we focus on at this stage are: is there evidence of an acute change in mental status from the patient's baseline? And does the abnormal behaviour fluctuate during the day? Does it tend to come and go, increasing and decreasing in severity? Feature 2 explores the level of inattention. And our questions here are: does the patient have difficulty focusing attention? Are they easily distracted? And are they having difficulty keeping track of what is being said? The third feature is disorganized thinking. The focus here is on: is the patient's thinking disorganized or incoherent? Are they rambling, or does the conversation seem irrelevant? Do they have an unclear or illogical flow of ideas? And is their thinking unpredictable? Are they often switching between subjects? And the final feature of the 4 is altered level of consciousness. Overall, how would you rate the patient's level of consciousness? Are they alert, which is normal, vigilant, hyperalert, lethargic, drowsy but easily aroused, in a stupor, difficult to arouse, or in a coma, unarousable? So a diagnosis of delirium requires feature 1, acute onset and fluctuating course, plus feature 2, inattention, as well as either number 3, disorganized thinking, or 4, altered level of consciousness. And these scores are recorded on the Confusion Assessment Method prompt sheet, which is MIDAS 89624, and you can see that here. As you can see, this sheet has some clear prompt space to record your answers. There are also some easy tick boxes at the bottom of the sheet, so it's really easy to tot up the patient's score. So when do we actually do the CAM for our patients? Well, for this we can use the delirium management pathway, which you can see here. On MIDAS, this is document 90197, but Let's just take a few minutes now to go down this pathway together, and we'll do that by meeting John. John's a patient here. He's 67, and he's come to hospital to have his gangrenous toe removed, and that resulted from his type 2 diabetes. John was really fit and healthy until about 2 months ago, and then his toe got so bad that his mobility was compromised severely, and that's really affected his activity levels. And as a result, his diabetes has become increasingly unstable, so he had to start insulin treatment. And now John has arrived in your ward after his surgery. Let's just take a few moments to recall some of those risk factors from the last video. Firstly, old age. John is 67, so he falls into the over 65 category. Remember, any patient over 65 is given a CAM assessment on admission. Severe illness. John's gangrenous toe and consequent surgery certainly ticked that box. Poor glycemic control. He's diabetic. He's recently started insulin treatment, so that risk factor is also present. And although the other risk factors are not necessarily present, John's history would certainly make him predisposed to delirium. So John's assessed on day 1 on admission using the confusion assessment method recording sheet, which looks like this. And you can see it's got sections to record the patient's scores every shift over the first 5 days. Now on admission, John only scores 2, and that's not enough to progress him down the delirium pathway. However, as we know, things can change for patients during their healthcare journey, and that's why it's vital that all patients over 65 are assessed every shift for 5 days. Because let's see what happens on day 3 for John. Abby was tasked with performing a CAM assessment for John. When she spoke to him, she noticed he wasn't very attentive, but that had been recorded in all the other assessments, and John's daughter Sue confirmed this was quite normal for him. He'd always been a bit scatterbrained, she said. However, on day 3 when Abby spoke to John, she also noticed he was quite lethargic, and that was a new feature. This lethargy seemed to come on quite quickly. When Abby asked Sue, Sue did say that John seemed a little bit more confused than normal, and that his lethargy was new. So Abby decides to use the FamCam with Sue. And that's that list of questions that are really useful in gathering information from family. Here it is. It's a series of questions, and it's number 90185 on Midas. Sue answers yes to questions 1, 2, 4, 9, 10 and 11. So Abby takes those answers and scores them on 90184. She gets a check in columns 1, 2 and 3, and this strongly suggests to her that John is experiencing delirium. Abby gives Sue the family information sheet on delirium. So just remember, if box 1 and 2 are ticked on the CAM assessment, plus either 3 or 4, then delirium interventions are activated. Abby's careful to document John's score on both the CAM sheet, which looks like this, so it's got sections to record, and on his clinical record. And then she goes straight to the intervention checklist to see what can be done to help John. So here's the CAM intervention checklist, and let's explore each of these interventions in detail. Firstly, Abby checks John's hearing. He doesn't wear a hearing aid, but if he did, she would check that the hearing aid was in at all times and that it was working. Next, she checks John's vision. Does John wear glasses? Yes, he does. So Abby encourages him to use them. She makes sure they're clean and also checks that the lighting is appropriate. Then she moves on to checking his environment. She gets some help and positions John's bed towards a window at the lowest level for that patient. She also displays this on the orientation board, which will be updated daily. She makes sure that the clock in the room is working, and Abby pops this delirium symbol onto the My Care plan. Abby is also very vigilant that there's no bed rail, and she inquires whether an ultra-low height bed is actually available for John. So, having taken care of hearing, vision and environment, Abby uses the delirium management pathway flowchart to check what other interventions can be put in place. Next, she looks at John's nutrition and hydration by encouraging oral intake and commencing fluid balance. She also requests a referral to a dietitian because of John's type 2 diabetes. And because John scored 3 of the 4 features, a pharmacy review is ordered. And all of this is documented on the Confusion Assessment Method Intervention Checklist. And then those CAM assessments continue until John's score is 0 for 48 hours. Now, because John's score was a 3, Abby also considers a false alarm and thinks about a patient watch. And that would entail a coding stamp on John's clinical record, which is signed by a clinician. That only needs to happen once. Luckily, by day 7, John has been scoring 0 on his CAM for 48 hours, so he's actually ready for discharge. And on discharge, a diagnosis of delirium is stated on his discharge summary. Throughout all of his stay, it's important that John and all of our patients are cared for with dignity, which includes reducing distractions, approaching from where the patient can see you, remaining calm and caring at all times, maintaining eye contact, and allowing time, so just resist that urge to rush. Try to keep changes of routine to a minimum, and use appropriate touch, especially if patients are upset. You know, even if John hadn't shown any signs of a delirium, he would have continued to have assessments as a matter of course every shift for the first 5 days of his stay, just like all the other patients over 65 on John's ward. Bill, for example, scored 0 on the CAM on all 5 days, so his assessments were discontinued. But Coro has shown a score of between 1 and 4 for days 4 and 5 of his CAM assessments, so his assessments will continue every shift until his score is 0 for 48 hours. Let's just recap what we've done in this video. We looked at the 4 features of delirium, and we went over the idea that if feature 1 and 2 are present, as well as either 3 or 4, then a diagnosis of delirium is suggested. We looked at that delirium management pathway and learned that any patient over 65 will be screened every shift for the first 5 days after admission. We recalled the questions that we asked patients and also understood the importance of using the FAM-CAM tool with family. And we looked at the interventions that can be used with patients who've been identified as experiencing a delirium. And throughout all of that, we remembered our Southern values and the importance for caring for all of our patients with dignity and with kindness. So we hope that this video training has given you more confidence to identify delirium using the CAM tools we have here at Southern and to take the actions necessary to improve positive outcomes for our patients.